My name is Ethan Mickelson. It's my pleasure to be joining you from the University of Washington in the Bioengineering Department, and more specifically the PUN Lab. And it's my pleasure as well to be sharing with you my research in engineering polymers for the resuscitation of trauma patients. So I want to begin by giving a little bit of background on the disease landscape that I'm seeking to treat. Hemorrhagic shock is the leading cause of death among traumatic injuries, and among causes of death in Americans under the age of 46, trauma accounts for almost half of all deaths, about 4 times as much as either cancer or heart disease. And so the pathophysiology of hemorrhagic shock is that it's a state that occurs after the body sustains a severe traumatic injury accompanied with severe blood loss. This causes the blood pressure in the circulatory system to collapse, leaving your circulatory system unable to adequately perfuse your tissues or deliver oxygen to those tissues, eventually causing death. And so the clinical solution to this should make some intuitive sense to you. When you've lost all this blood, you need to be replacing it with some other fluid, and that's why we call it fluid resuscitation. The prime choice for this will always be whole blood. There's no replacement for what should be in your bloodstream. It's blood. But it may surprise you to learn that blood products are generally unavailable in the pre-hospital setting where all of these traumatic injuries are occurring due to their complex storage and refrigeration conditions. And I want to expand on this a little bit by saying that 90% of all traumatic injuries worldwide occur in low and middle income countries where the average transit time to a trauma center is regularly as long as 6 hours. So this really underscores the importance for therapies focused towards the pre-hospital setting. And so without the availability of blood products, our first responders are forced to turn to synthetic alternatives like crystalloid or colloid fluids. And these have a history of underperforming, and it's been the only real clinically used therapy for about 60 years. And I'm going to expand on some of these inadequacies. Namely, it's that there are these large volume resuscitants. You require several liters of treatment. So these big bags of fluid really just aren't practical in the pre-hospital environment in the first place, especially when you consider that they need to be warmed to physiological temperature before administration to avoid giving your patients hypothermia. To expand further, they operate on the principle of aggressive fluid replacement, which means that if a patient experiences a 60% blood loss, they may need a 3-fold replacement of that blood that was lost, meaning they would need a 180% dose of their blood volume worth of crystalloid of colloid solutions. And so you can imagine this causes your patients to quite literally swell up. It spikes their blood pressure so much, though, that it pops any clots that the body has already formed, trying to stop the bleeding. And worst of all, it induces a paradoxical and unacceptable coagulopathy within the patient. And that's a term you'll hear me say a lot throughout the presentation. Coagulopathy just refers to an impaired clot formation. And if there's one thing you should not take away from your patient that is bleeding and dying, it's their ability to coagulate. So this has been a really neglected area of medicine. And perhaps that's not surprising that some of the best options that we have for these patients are these glorified saline solutions when you look at the funding landscape of traumatic injury. It's absolutely dwarfed by cancer and infectious disease research, and that's probably why we have all these beautiful cancer therapies that you've seen some of today relative to traumatic injury. And you can see the pie chart again just to show this in contrast to its societal impact. So in the PUN Lab, we decided to approach this with the solution of making a low-volume resuscitant. And so a low-volume resuscitant is a substance that can replace several times its own volume worth of blood. So in a patient of hemorrhagic shock that has experienced a 60% blood loss, you can administer a dose of only 10% the total blood volume of our therapeutic polymer to replace that blood. And I'm sure you're wondering how that's possible. And LVRs function through creating oncotic pressure gradients in the patient's vasculature. These are really high molecular weight therapies that in your vasculature are displacing the water that remains, and through some extrapolated principles of osmosis, they're able to pull water in from the other areas of the body, your muscle tissues, your fat tissues. And this is a really powerful approach to this disease state because you're essentially resuscitating the patient with their own fluid that is lying latent in their body just outside of the bloodstream. And so when you're able to rely on the water that's already in the patient, this shrinks your dose size considerably. And this makes this a really highly portable therapy, which is extremely important in the pre-hospital setting. It also makes this more efficient. And beyond that, it doesn't require warming to physiological temperature because it's such a small volume. So the first LVR therapy I want to acknowledge is polyethylene glycol 20K. It's a regular old off-the-shelf PEG. It was originally discovered to be a serendipitously potent resuscitant when it was used as a negative control in a study by Martin Mangino at Virginia Commonwealth University. So since its accidental discovery, it has been developed really well. Mangino's done a lot of excellent work, and they found that it is 15 times more potent than the crystalloid and colloid solutions used clinically. But beyond that, there are some significant drawbacks and shortcomings to the use of PEG-20K in resuscitation, namely that it is coagulopathic. It inactivates your platelets, and this is really the one thing that you can't do. It puts the nail in the coffin to a certain extent. But beyond that, PEG is just PEG. You can't change it too much. You can add extra branching points, but it's not necessarily a tunable platform, and it kind of limits your ability when you're taking a molecule to clinic. If you need to make tweaks along the way in your development, you can't really do that. And you may shrug your shoulders at this, but there is concerns of PEG allergies that rose considerably with the COVID-19 vaccines. And I say you may shrug your shoulders because in the context of this therapy, when you're administering so much PEG, it's about 10 million times more that you're injecting into your patient than was enough to elicit a response in some patients receiving the COVID vaccine. So I want to outline a few of the goals that we had when we set out to develop this LVR. We wanted to develop an LVR that had a tunable polymeric platform, possibly achieved through side chain functionality. Most importantly, we wanted an LVR that did not impair the patient's ability to coagulate and therefore was non-coagulopathic. And ideally, we would create a therapy that was more potent than PEG-20K and would allow us to move from an infusion, shrink the dosage size down into a single bolus injection. And And for bonus points along the way, we wanted to uncover the trends in LVR polymer design. Do bigger or smaller polymers of different chemistries and different architectures affect coagulation, or do they affect in vivo performance and their potency as a resuscitant? And so the first step down this path was to determine a polymeric platform that we would build our LVRs onto. And in the Pun Lab, we're polymer chemists. We have a lot of experience with methacrylate polymers, so we decided to use these. They polymerize really nicely with other monomers. If we decided to get fancy later on in therapy, they'll play nice with any other ideas we might want to introduce. But more importantly, in the short term, the side chain, the R group, you can see you can really tack anything onto this polymeric platform, and it gives you an extra layer of customizability that you don't have with other polymeric platforms. So now that we had determined methacrylates, we needed to decide on some methacrylate monomers that we would polymerize into our LVRs. So at this time, we really only knew a couple of things for certain. We knew that we needed a monomer that was highly hydrophilic, and similarly, we needed monomers with high water recruitment efficiency that would bind water molecules very tightly on the molecular level. So we decided to work with GMMA. GMMA is a really high-density hydrogen bonding monomer, and you can imagine, remember, these are polymers, so you have this dense network of glycerol monomethacrylate hydrogen bonding with itself, and with the solution, it can become really potent. And similar advantages are seen with the two Zwitter ionic monomers that we worked with, SBMA and MPC, and they have the added benefit of the Gibbs-Donan effect, which essentially states that charged particles on one side of a permeable membrane, like your blood vessels, are able to disrupt the equilibrium of fluid flow such that you're getting a lot more fluid pulled towards the charged particle, which you would imagine is very useful for our purposes in resuscitation. So we do all of our polymerizations in the Pun Lab with raft polymerization. So our first step was to make polymers of the aforedescribed monomers, 100, 200, and 300 monomer units long, 100 being the shortest, 300 being the longest. And when we measured the size of these polymers in solution, and that's their radius of gyration, their RG, we found that methacrylate polymers of about 200 monomer units long gave us about the size we wanted, the size of PEG-20K, which had already been somewhat optimized by the Mangino group. So knowing that, we moved forward, and the first test that we needed to perform on these polymers was rotational thromboelastometry to probe whether or not our polymers would take away a patient's ability to coagulate. So this is a clinical test with a somewhat unusual plot, but all you need to know about these plots here is that the amplitude describes the thickness and robustness of your blood clot. So the thicker the plot, the thicker the clot. And you can also look at the clotting time, you can also look at the alpha angle, which describes the clot formation kinetics. The faster, the better. And so when we looked at these results, you can see the alpha angle clot formation kinetics on the bottom left and GMMA in blue. We found that GMMA polymers did not adversely affect coagulation. And this was a really exciting result because there have been no resuscitants shown to not impair the patient's ability to coagulate. And I'm sure you're thinking, how is that possible? But it's been a very neglected criterion for trauma therapies. And contrarily, unfortunately, we did see early on that our SBMA and MPC polymers did significantly adversely affect coagulation, both in the rate of clot formation and in the total clot stiffness. So we decided to remove MPC from the study before moving on to our in vivo investigations in our animal model. So in order to create an animal model of hemorrhagic shock, we worked with rats, and we fit them with a catheter to withdraw 60% of their total blood volume until their blood lactate reached 8 millimoles. And that is kind of just a standardized way that we could point to the measurements in the blood and say this animal has entered hemorrhagic shock in a standardized manner, and it was good to begin the infusion at that time. And so looking at these infusions, you want to look at the arterial pressure shown on the y-axis. I showed the desired arterial pressure that we're aiming to meet, shaded in gray. Unfortunately, the GMMA polymers, which did not impair coagulation, failed in adequately achieving and maintaining the arterial pressure across the duration of the study. But contrarily, our zwitterionic SBMA polymers of 200 and 300 units long did achieve the desired pressure and maintain it throughout the duration of the study. So it's a shame that it would impair coagulation. So at this point, we were left with two polymers that were excellent at opposite components for a therapy that we really needed both of these criteria to be hit. So we resolved that it would be much easier to try and improve the potency of GMMA rather than to try and fix the problem with coagulation, which is a lot more abstract with SBMA. So upon performing a literature search, we found pretty simply that really highly branched polymers have better blood compatibility, they have better renal clearance kinetics, and most importantly, these branched polymers have a maximized surface area for interactions with their solvent, which is in this case water. So the more water you can interact with, the more potent your resuscitant. And I also wanted to acknowledge Dr. Kazakadathu's work here at UBC while I'm here, because his work was really helpful in making this decision to move forward. And to create polymers with an increased surface area, we went about synthesizing radiant star polymers. And so radiant star polymers are essentially formed in a two-step process. First, you need to polymerize a core from which multiple polymer chains can be built. So that's what I have shown here. The macro CTA is our core, and then from that you can perform RAF polymerization more or less as normal to get multiple polymer chains coming off of a shared core. And this really increases the density of the polymer within a given radius of gyration and makes them much more potent. And if you're not one for chemical structures, this is all you really need to know. We form the core, and then from there we extend outward in several directions. So at this time, we needed to revisit our coagulation assays and pray that the non-coagulopathic nature of the GMMA polymer was not removed when you formulate it into the radiant star architecture. And you can see that they stay within the range of our negative control, saline, and as such, we are able to conclude that radiant star GMMA polymers do not impair coagulation. You can see that all other tested ones do, and the literature will tell you the same thing. I wanted to also mention that we tested coagulation. We probed for any risk of coagulation issues also with a thrombin generation assay, as well as platelet activation and platelet aggregometry assays, all of which GMMA polymers passed. And so next, we needed to revisit our in vivo model to see if the radiant star architecture was successful in increasing the potency. And we were relieved to see that in the radiant star architecture, both our GMMA polymers and our zwitterionic SBMA polymers were able to achieve and maintain the desired range of mean arterial pressure throughout the study, which led us to be able to conclude that radiant star GMMA polymers can achieve your desired pressure. And as I wrap up, I want to share some key outcomes from this study where we identified radiant star GMMA polymers as a key resuscitant for future medical use. The first key outcome being that our LVR polymer can rescue animals from a blood loss of 60% total blood volume with only a 10% total blood volume dose, constituting an 18-fold increase in potency over the currently clinically used resuscitants. The second key outcome being that our LVR polymer achieves mean arterial pressure within the desired range for damage control resuscitation, which just describes the modern understanding that a physician would use to approach the treatment of hemorrhagic shock. It's called damage control resuscitation. The third key outcome being that our LVR polymer presents the first ever synthetic therapy to achieve resuscitation without impairing patient coagulation. So altogether, these key outcomes constitute a huge victory for the improvement of the treatment of hemorrhagic shock in the pre-hospital environment. And I want to acknowledge and thank the gracious funding of the NIH and the Department of Defense, as well as my colleagues in the Pun Lab and our collaborators in the Department of Emergency Medicine. I want to explicitly thank my advisor, Susie Pun, as well as my mentor, Trey Pichon, shown in the bottom left here, without whom this work would not have been possible. And also thank you to UBC for giving me the opportunity to share my research. I'm very grateful to be here, and I can take any questions now.
Thank you, Ethan, for your really wonderful presentation. My son just texted me while you were giving your talk, and he's just finished his paramedic course, which I'm quite worried about because my wife and I are very scared of the traumas that he might now be seeing. He's a nursing student at UBC, and this is his great idea to make money in the summer.
Well, that's exciting. I hope we can have some overlap.
Wouldn't it be great if this work can eventually trickle down into the frontline peoples and ambulances and things like that?
I couldn't agree more. Yes.
So any questions for Ethan? Oh, there's a question up there.
Yeah, thank you for your question. So the next steps for us are to evaluate the biodistribution profile, as well as to investigate whether or not our resuscitants can maintain the pressure for much longer periods of time. I mentioned that for most of the citizens of the world, the trauma center can be as far away as 6 hours. So we really need to make sure that we can maintain that pressure close to that range. Right now, we've only evaluated up to about 90 minutes. So those will be the key next steps moving forward, as well as to increase the potency even further. I mentioned that our eventual goal is to move from an infusion into a single bolus injection. So you can imagine how transformative it might be if you can skip the step of having to fit your patient with the PICC line and just inject the polymer. This would also open up a lot of applications for the speed of the treatment, maybe even make this usable for military field use and tactical combat casualty care, which is some of the goals of our funding from the Department of Defense.